Clinical vignettes, pulmonary hypertension cases with different presentations. Case 1, idiopathic pulmonary arterial hypertension, Group 1. A 27-year-old woman presents with progressive shortness of breath, fatigue, and episodes of syncope while climbing stairs. She has no history of smoking, lung disease, or heart disease. Physical examination reveals a loud P2, right ventricular heave, and signs of right heart failure. Echocardiography shows right ventricular hypertrophy and an estimated pulmonary artery pressure of 50 mmHg. Question: what is the best initial diagnostic test? A. Right heart catheterization. B. Chest X-ray. C. High-resolution CT scan. D. Pulmonary function tests. Answer: A. Right heart catheterization. Explanation: this patient likely has idiopathic pulmonary arterial hypertension, PAH, a condition that primarily affects the pulmonary arteries, WHO Group 1. The gold standard for diagnosis is right heart catheterization, which will show an elevated mean pulmonary artery pressure, MPAP 25 mmHg, and a normal pulmonary capillary wedge pressure, PCWP, top 15 mmHg. Case 2, pulmonary hypertension due to left heart disease, Group 2. A 65-year-old man with a history of hypertension and heart failure with reduced ejection fraction, HFrEF, presents with worsening dyspnea on exertion and orthopnea. He has bilateral lung crackles and jugular venous distension, JVD. Echocardiography reveals a left ventricular ejection fraction, LV, of 35% and pulmonary artery systolic pressure, PSP, of 48 mmHg. Question: what is the most likely underlying cause of his pulmonary hypertension? A. Chronic thromboembolic disease. B. Left ventricular dysfunction. C. Chronic obstructive pulmonary disease, COPD. D. Connective tissue disease. B. Left ventricular dysfunction. Explanation: this patient has pulmonary hypertension secondary to left heart disease, Group 2. In this case, elevated left atrial pressures due to heart failure cause pulmonary venous congestion, leading to increased pulmonary pressures. Right heart catheterization would show elevated pulmonary capillary wedge pressure, PCWP, 15 mmHg. Treatment focuses on managing left heart disease, diuretics, ACE inhibitors, beta blockers, etc., rather than pulmonary vasodilators. Case 3, pulmonary hypertension due to chronic lung disease, Group 3. A 70-year-old former smoker with a history of COPD presents with worsening dyspnea and exercise intolerance. He has pursed lip breathing, distant breath sounds, and peripheral cyanosis. His oxygen saturation is 88% on room air, and arterial blood gas, ABG, shows hypoxemia with mild respiratory acidosis. Question: what is the most appropriate treatment for this patient's pulmonary hypertension? A. Endothelin receptor antagonists, bosentan. B. Calcium channel blockers. C. Supplemental oxygen. D. Sildenafil, PDE5 inhibitor. Answer: C. Supplemental oxygen. Explanation: this patient has pulmonary hypertension secondary to COPD, Group 3. Chronic hypoxia leads to pulmonary vasoconstriction and subsequent pulmonary hypertension. The best treatment is long-term oxygen therapy, if SpO2 88%, which reduces pulmonary vasoconstriction and improves survival. Pulmonary vasodilators like bosentan and sildenafil are not indicated in Group 3 PH. Case 4, chronic thromboembolic pulmonary hypertension, CTH, Group 4. A 45-year-old woman presents with progressive exertional dyspnea and fatigue for 6 months. She had a deep vein thrombosis, DVT, and pulmonary embolism, PE, 1 year ago, but stopped anticoagulation after 6 months. Physical exam reveals a loud P2 and a systolic murmur at the left sternal border. A ventilation perfusion VQ scan shows mismatched perfusion defects. Question: what is the most definitive treatment for this condition? A. Lifelong anticoagulation. B. Pulmonary thromboendarterectomy. C. Pulmonary vasodilators. D. Diuretics. Answer: B. Pulmonary thromboendarterectomy. Explanation: this patient likely has chronic thromboembolic pulmonary hypertension, CTEP, Group 4. The best diagnostic test is a VQ scan, which shows mismatched perfusion defects. The definitive treatment is pulmonary thromboendarterectomy, PTE, which removes organized thrombi from the pulmonary arteries. Riociguat, a soluble guanylate cyclase stimulator, can be used in inoperable cases. Case 5, pulmonary hypertension due to connective tissue disease, Group 1, PAH secondary to scleroderma. A 52-year-old woman with a history of systemic sclerosis, scleroderma, Presents with exertional dyspnea, Raynaud's phenomenon, and swollen fingers. Transthoracic echocardiography, TTE, reveals an enlarged right ventricle and an estimated pulmonary artery systolic pressure of 55 mmHg. Right heart catheterization confirms elevated pulmonary artery pressure with a normal wedge pressure. Question: what is the best initial therapy? A. Nifedipine, B. Sildenafil, C. Bosentan, D. Corticosteroids. Answer: C. Bosentan. Explanation: this patient has pulmonary arterial hypertension, secondary to systemic sclerosis, group 1 PH. The first-line treatment includes endothelin receptor antagonists, bosentan, ambrisentan, which block endothelin 1, a potent vasoconstrictor. Other options include PDE5 inhibitors, sildenafil, and prostacyclin analogs, epoprostenol, treprostinil. Calcium channel blockers, nifedipine, are only used in rare cases with a positive vasoreactivity test. Summary of pulmonary hypertension groups and treatment. Cause, treatment. Group 1, PAH, idiopathic, connective tissue disease, scleroderma, congenital heart disease, endothelin receptor antagonists, bosentan, PDE5 inhibitors, sildenafil, prostacyclin analogs. Group 2, left heart disease, heart failure, mitral aortic valve disease. Treat underlying heart disease. Group 3, chronic lung disease, COPD, ILD, hypoxia. Supplemental oxygen. Group 4, chronic thromboembolic disease, CTEPH. Pulmonary thromboendarterectomy, riosuguat, anticoagulation. Miscellaneous, sarcoidosis, chronic kidney disease. Treat underlying cause. Would you like additional clinical cases?